Hello, Dr. Gauri.
Hello, ma'am. Good evening.
Hey, good evening, Dr. Sai. I'm just checking how to use my virtual backdrop.
Sure, ma'am. Sure.
I'll have to go to some.
Are you using your laptop, ma'am?
Yeah, I'm using my laptop.
Okay, I'll just check it now. Yeah, on the left bottom corner, there's a start video button, ma'am. Next to that, there is a choose virtual background
A
option.
left corner, upper corner, is it?
Lower, ma'am. Lower.
Left lower, I'm seeing mute, stop video, security, participants.
Is there a start video, ma'am, that you see?
Yeah, I can see start video. Okay,
Yeah,
I
in
choose
that you get
virtual
an option.
background. Okay, I got it. Uh, Now, how do I go to? Is this better?
I'm sorry, ma'am. 1 second. I'm having some network issues. I'll just check.
Okay. I think there is an issue with this backdrop, right? Hmm.
Hello, Dr. Shilpa. Can't hear you, doctor.
Yeah, I've just unmuted, but I don't know how to do this backdrop.
Yeah, place the virtual background, but you have to move towards right. Wall should be empty, else white background should be there behind. Else it will not appear properly.
Can't hear you.
Can you hear me, doctor?
Yeah. I can hear you.
There is a problem with your virtual background.
Yeah,
You
how
should
do I adjust this?
probably move towards right, or your background should be white or some other color, plain color.
Okay.
If there are any hello,
Yeah, I can hear you.
can you adjust, doctor? Try to adjust your screen.
How do I adjust the screen? See, if I come closer, I can get it. But can you come on call, please?
Can you make it blur, doctor? Can you make it blur instead
Can you come on
rather than
call, please?
Mr. Vignesh, if
try
you
to
just call up Shilpa madam. Can you call her up? Do you have a number? Shall I send it to you?
No, I just spoke to
I have
her.
Okay. Okay.
Mr. Vignesh, is this better? Mr. Vignesh?
Yes, doctor.
Is this better? Is this better?
Can you please the virtual background, doctor?
Virtual background. Okay. I'm just the minute I put the virtual background, this is what has happened. Yeah, that is the reason. How do I choose the blur mode in this? Video setting in the computer. Okay. Choose, yeah, video settings. Yes. I've clicked that. See myself and background and effects. Yes, yes. Yeah, I got it. Now, video filters, virtual background is there. Blur my video option is not there. None and Teams meeting background is there because this is blur is not coming. Okay. Okay, fine. Yeah, because mine is only a small this thing. Basically, presentation comes, no? So yeah. Okay, fine. Great, great, great. Thank you so much, Mr. Vignesh. Thank you. Thank you. Bye.
Good evening, everybody. It's a beautiful Friday evening, and we are here to attend this lovely lecture on deprogramming, which is the first step to occlusal rehabilitation. We will begin the lecture and today's webinar shortly. So let's hope that we can start in another 2-3 minutes. We'll just wait for all the participants to just come in. In another minute or so, we will be starting today's program. Good evening. Today is a wonderful evening, and we are all here for this much awaited webinar brought to you by Global Dental Academy and Implant Study Group. This webinar, as you all know, is on deprogramming, the first step to occlusal rehabilitation. And we are here to listen to words of wisdom by the stars, the original gurus of implantology and rehabilitation and restorative dentistry, as well as maxillofacial surgery. This course, this webinar will be, we will be getting to hear from Dr. Girish Rao, sir, Dr. Anand Krishna, sir, and of course, Dr. Shilpa Shetty, ma'am. Just a few housekeeping rules to begin with. We request everybody, all the participants, to keep their audios on mute, and we will take the questions at the end of it. So good evening and welcome to one and all.
Can I start, Dr. Sai?
Just 1 second. I think he'll just introduce you. Dr. Girish will.
Okay, fine.
Yeah.
Yeah, so then I'll stop sharing the screen.
No, just let it be on the thing.
Okay, fine. Yeah.
Good evening, Shilpa. Can you hear me? Good evening,
Yeah, hi,
Anand.
hi, Dr. Girish. How are you?
Hi. How are you guys doing?
All good, all set to go.
Fantastic.
Hello and very good evening to all of you. I am Dr. Sri Gauri. Just to give you all a brief introduction to the Global Healthcare Academy. I hope I'm audible.
Yes,
Global
Gauri, you are.
Healthcare Academy has been instituted with the mission to develop competent and compassionate human resources for the healthcare sector. The Global Healthcare Academy, the purpose of it is to bridge the skill and knowledge gap between formal education and needs of the healthcare industry. Another wing of Global Healthcare Academy is the Global Dental Academy. Today's teaching and learning needs are rapidly evolving in real time, and thanks to the swift and seamless knowledge transfer across multiple media vehicles, conceptualized and brought to you by renowned leaders and practitioners in dentistry. This platform will help the budding dental students and professionals to make most experiential learning opportunities. From the Global Dental Academy, we have a lot of programs that we do, both online and offline. We have our signature implant fellowship group. We have an advanced surgical module, advanced prosthetic module. We are also introducing a course on robotics to introduce robotics to maxillofacial surgeons. And we also have different courses such as digital dentistry and courses like we are launching today as well, which is about full mouth rehabilitation, and a lot of interesting things happening, which we will portray to you both on the online as well as offline modules.
So the director of our course are Dr. Girish Rao sir and Dr. Anand Krishna sir. And I'm sure that none of you need the introduction to any of these stalwarts, but it is my pleasant opportunity and my duty to introduce these greats. Dr. Girish Rao sir is a maxillofacial surgeon and head of oral and maxillofacial surgery in various departments. He completed his undergraduation from the renowned Government Dental College, Bangalore, and went on to finish his maxillofacial surgery from Government Dental College, Madras. He is a gold medalist throughout. Post his post graduation, he went on to train in the UK and has been one of the stalwart surgeons not just in India but across the globe. Sir, we welcome you for today's program, and we would want you to give your valuable words to this gathering.
Thank you, Swaroop. Thank you, Gauri. Good evening, my dear friend Shilpa and Dr. Anand Krishna. I'm so glad today we are having a webinar on this deprogramming, which is very, very important when we are talking about full mouth rehabilitations. I'm a hardcore surgeon, and being a maxillofacial surgeon, took up implantology just about almost about 25, 30 years back, and have been, placing implants. And I'm very, very fortunate to have an ace a prosthodontist who has been dealing with, the rehabilitation bit and the prosthetic aspect, which is very, very crucial. In fact, one of the things which we need to understand when we are dealing with implantology is the fact that everything is done with the end in mind. End in mind is, at the end of the day, our patient is very, very much interested, not in the number of implants which you're placing, but what crowns, what's the restoration which you're giving, because that ultimately dictates the function and aesthetics. So whenever you're looking at basically doing implants, you need to really look at what the final outcome is, where we are heading to, and work backwards. So this is something which is very, very crucial. And I think it's very, very important that every implantologist, be it a surgeon, a prosthodontist, or a periodontist, or a general dentist, should understand the key thing for your success and for the patient's comfort, and for the patient to really effectively use the implants which we have put in, is basically getting the occlusion right, getting the teeth in the right position. They have to speak properly, they have to chew properly, and they have to look properly. This is the goal with which we need to do. And unless you get your basics right, unless you get your fundamentals right on this aspect, you will never be successful. And I'm so glad that we from Global Dental Academy, we are introducing this program today. The webinar, we have ideas of having maybe on a monthly basis, regular short teaching programs. We call this as focused learning programs, which can transform your day-to-day practice. Our goal with Implant Study Group, which we started 22 years back, is the fact that knowledge shared is knowledge grown. So then about 2 years back, we merged with Global Dental Academy Implant Study Group, became Global Dental Academy, so that we could take this to the world. Our whole goal was basically reach out to the whole world so that every dentist should be placing proper implantology. With that in mind, we started this training program, and I'm so glad that thousands of dentists, thousands of specialists, be it a prosthodontist, a periodontist, or a maxillofacial surgeon, or an endodontist, or many times I've seen even oral medicine and orthodontists coming in and basically placing implants and doing full mouth rehabilitations. This is very, very heartening to see that everybody is accepting implantology today to do it in their practices, and we want to make it more effective. The key is how you can get predictable outcomes, how you can bring in a better outcome, better success. And that is the goal, and that's our mission with which we are doing this Global Dental Academy seminars, webinars, and training programs. We were probably one of the first in the country to introduce zygoma implants, first to do tooth in a day concept, first to do trefoil concepts, and do patient-specific 3D implants. And that is something, virtual surgical planning, which we do on a day-to-day basis. And we want to introduce robotics today into implantology, into maxillofacial surgery. And I believe that technology, if it is used in the right way, it can make your life so much easier, make it more predictable, get better outcomes. And that's the goal with which we have done. And I'm so glad we have both Dr. Anand Krishna and my dear friend, Dr. Shilpa Shetty, who is a superb clinician, one of the finest prosthodontists in the country, who will be taking you through in the next 1 hour on this very, very important program. Let me sign off here and ask Shilpa to take the stage and teach us how her tricks has made her very, very successful. Thank you.
Thank you so much, Girisha sir, for introducing us to Implant Study Group and Global Dental Academy, and sharing with us that knowledge shared is knowledge grown. Before we start off, I would like to also introduce Dr. Anand Krishna. It's my honor. He is the director of Global Dental Academy and an ACE clinician, renowned prosthodontist and implantologist. Did his undergraduation from the Government Dental College, Bangalore, and post-graduation from A.B. Shetty Memorial Institute. He has been teaching and training in prosthodontics and implant prosthodontics for over 2 decades now. And the value that you get out of learning from him is enormous. Once again, welcoming Dr. Anand Krishna sir for the webinar. Sir, would you like to get a few words to all the participants today?
Sure, Dr. Gauri. Thank you so much for the introduction. Yes, this program was more because of the feedback that we were getting during the courses that we were doing, that a lot of people wanted to learn more about full mouth rehabilitation. So this is kind of a teaser to invoke interest among people and give it the right direction. You know, the first step towards complete oral rehabilitation is deprogramming. And there are a lot of myths that is floating around. There's a lot of controversies around this. We just wanted to have a quick webinar on this. Probably we'll follow it up with another program, which is more full-fledged, involving a lot of things on occlusion, a lot of things on planning, baseboard transfer, and things like that. For a clinician to take up complex rehabilitations when it comes to natural teeth, and also to treat tooth wear disease, which is becoming more and more common today if you see in the general practice. So that's the whole goal. So I will join in at the end of the webinar. Dr. Shilpa has to go to a lecture, and then we'll take up some things for discussion and probably give my inputs during that time. Thank you so much for giving me that introduction, Dr. Gauri.
Thank you, sir. It's a pleasure.
Now it is my proud privilege to introduce the speaker of the day, Dr. Shilpa Shetty ma'am. Dr. Shilpa Shetty is an ACE prosthodontist based in Bangalore and a gold medalist from the prestigious A.B. Shetty Memorial Institute of Dental Sciences, Bangalore. Her pursuit for excellence led her to acquaint herself with various implant as well as restorative fellowship courses in various parts of the globe, including under Dr. Morgan Olson, and has shown enormous hunger to continuously enhance her skills. In 2012, Madam received the esteemed fellowship and diplomate from the International Council of Oral Implantology. She is also a fellow of the prestigious Royal College of Physicians and Surgeons. Ma'am specializes in variety of advanced dental procedures, including oral implantology, smile makeovers, aesthetic dentistry, laser dentistry, as well as full mouth rehabilitation. She has also been actively involved in various organizations such as the Indian Dental Association, Indian Prosthodontic Society, Indian Society of Oral Oral Implantologists, as well as Women in Implantology. It is our proud privilege to listen to you, ma'am, and over to you for the entire program now.
Just a quick input to the admin. I think Zoom is giving some trouble in people joining. I have 2 laptops in front of me and I'm trying to join through both the laptops, but I'm not able to log in. I'm just logged in through my phone. So if there's something in the backend that you could handle, that would be great. But I'm sure a lot of people are trying to join and they're not able to.
Thank you so much, Dr. Girish, for your wonderful introduction. Thank you, Dr. for giving me this opportunity. As you rightly said, we've been discussing on starting something on full mouth rehabilitation, as that's a need of the hour. And thank you, Dr. Sai and Dr. Gauri, for moderating the session. So I'm going to talk on deprogramming. That's the first step towards occlusal rehabilitation. Thanks to Implant Study Group in association with Global Dental Academy for organizing this fantastic lecture on deprogramming. So today's learning objectives. At the end of the session, we should be able to understand what is centric relation occlusion and what is maximum intercuspal position occlusion and what are deprogrammers. The whys, hows, types, and the indications and the contraindications for deprogramming. So before we begin, let's understand the stomatognathing system or the head and neck system or the orofacial complex. Now, this is primarily comprised of the temporomandibular joint, neuromusculature, and the dentition. So whenever there is a disharmony or instability that could be seen in the form of TM disorders, attrition, or tooth wear, or you could have pulpitis and periodontitis, or it could be something to do with the occlusomuscular dysfunction. So the first step when we are doing a full mouth rehabilitation is to ensure that the dentition or the restorations what we are planning to give in full mouth rehabilitation is in harmony with the temporomandibular joint and the neuromusculature. And the first step to achieve that is by obtaining an accurate centric relation record. It's highly recommended that to do a full mouth rehabilitation, you need to have a semi-adjustable articulator and a face bow. Now, you might ask why? Because a semi-adjustable articulator or a fully adjustable articulator accepts the face bow records and a centric relation record. What is a face bow? A face bow is used along with a semi-adjustable articulator or a fully adjustable articulator. It does 2 functions. The first, it registers the relation of the maxilla to the opening and closing axis of the jaws or the hinge axis. And then it transfers that particular relationship to the articulator so that the upper cast or the maxillary cast is in the same axis as that in the articulator. it should be the opening axis of the head and neck, or the joint should be in the similar position as in the articulator. And the next is the centric relation record. Getting an accurate centric relation record and mounting the cast in centric relation is the first step towards occlusal rehabilitation. Therefore, we never suggest to use a mean value or a 3-point articulator or a 2-point articulator for recording or for fabricating your full mouth rehabilitation restorations. Why so much of importance to centric relation? And why, we need to understand what is a centric relation. There are around 7 definitions available in the literature, but here I would like to talk about the definition given by the Glossary of Prosthodontic Terms. That is, it describes the centric relation as a maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of the respective disc. This is the articular disc. And this complex, that is a condyle and the articular disc complex, lies in the anterior superior position of the glenoid fossa, or against the slopes of the articular eminence. This position, now this is the articular eminence and this is your glenoid fossa. Okay, this is your retrodiscal tissues, this is the condyle, and this is your articular disc. The next sentence is equally important because it says that this position is independent of tooth contact. So please remember, the teeth do not dictate the centric relation position. And it is clinically discernible when the mandible is directed superiorly and anteriorly. Number 3, it is restricted to a purely rotational movement about the transverse horizontal axis or the hinge axis or the opening and closing axis of the jaws. So primarily, there are 2 movements of the condyle. The first one is the rotational movement and the second is translatory movement. Now, when the condyles are in the rotatory movement, that is when the joint or the condyles are in centric relation position. So we need to record our bite registrations when the condyle is in the glenoid fossa. But why? Why we should insist on centric relation position? Because it is a reproducible position, it is a repeatable position, and the patients are very comfortable in this position, and the jaw is taken to this position during swallowing. So for the physiologic functions as well, centric relation position is very, very important. And the centric relation position, when we record our centric relation bite records, we have to ensure that, as I said earlier, that the condyles need to be in a rotational movement or in the glenoid fossa. So in any interincisal opening, up to 25 millimeters, if the condyles are still in the rotational movement. Beyond that, the condyles begin to translate. So we cannot have more interincisal opening and put our bite registration paste. So dear members, please remember, this is very, very important when you record your centric relation records. Now, before we go further into centric relation and maximum intercostal position, I would like to briefly take you through the different muscles, that's the masticatory muscles, which are responsible for positioning the mandible. We have masseter, we have medial pterygoid muscle, and we have temporalis. These are the primary muscles which are responsible for elevating the mandible. So they are elevator muscles. And next is the lateral pterygoids. The lateral pterygoids are one of the most important muscles when it comes to understanding the centric relation position and maximum intercuspal position. Now, in lateral pterygoid, you have two heads. The first one is the superior head of lateral pterygoid, and the next is the inferior head of the lateral pterygoid. The inferior head of the lateral pterygoid is primarily responsible for depressing the mandible or opening the jaw. So, this muscle is 3 times the size of the superior head of the lateral pterygoid. Both of them, though they are known as lateral pterygoid, superior head of the lateral pterygoid assists in elevating, and the inferior head of the lateral pterygoid assists in depression. So this is the inferior head of the lateral pterygoid. This inferior head of the lateral pterygoid comes and inserts into the pterygoid fovea or the neck of the condyle. So it helps in positioning the condyle during opening and the sideway movements. The bilateral contraction of the inferior lateral pterygoid assists in protrusion of the mandible, and the unilateral contraction of the inferior head of the lateral pterygoid moves the jaw to the contralateral side, along with the medial pterygoid of the ipsilateral side. So this, please remember the inferior head of the lateral pterygoid, because I'll be talking about it much more in the later slides. Now, what is maximum intercuspal position, or MIP? MIP is where this maximum contact of the upper and lower teeth, and this particular position is independent of the condylar position. So to say that in very few patients, probably, I was going to the literature and it said around 10% of the population, the centric relation and the maximum intercuspal position coincide. 90% of them have a slide. Now, it's very important for a clinician to understand, especially when you're doing full mouth rehabilitation, do not register the bite in maximum intercuspal position. You need to develop, or you need a technique to get the joint into centric relation position. And from there, you need to understand why the joint, or how much is the slide which is happening for the mandible to move towards maximum intercuspal position. Sometimes it could be physiologic. The patient just adapts to it without any symptoms. Sometimes it could be pathologic. The patient comes back with the pain in the tooth, the patient has pain in the muscles, the patient has headaches sometimes, and the patient has temporomandibular joint disorders in chronic cases. Or the patient can have severe attrition, because that is what the jaw does. Whenever there is a high point, the muscles adjust the jaw in such a way that there could be attrition of that particular segment. So this is very, very important to understand what is centric relation and what is centric relation occlusion and what is maximum intercuspal position. So please do not record your bite or a centric relation bite, or your, like the bite which is where you're supposed to mount your cast should be in centric relation, but not in MIP. These are two different entities, centric relation position and maximum intercuspal position, as I have discussed earlier. Before we go further, let's understand what is proprioceptors. Now, these are receptors present in the periodontal ligament of the teeth. Now, they sense the load placed on the tooth. So whenever there is, it's easier, if you recollect, it's easier to record centric relation position in an edentulous patient because there are no teeth, no proprioception. It's easier to record in implants. Why? Because there are no proprioceptors around the implants. So whenever there are proprioceptors, or whenever there are teeth, that means there is proprioceptors, and this dictates the muscle position. So when there is a high point, so what does the proprioceptors do? The proprioceptors send signals to the inferior lateral pterygoid to adjust the jaw to such a position that there is no pain on the tooth and the jaw moves or deviates to the position in such a way that there is maximum intercuspation at the same time. So the muscles sort of protect the teeth from getting overloaded. So that is what the proprioceptor's function is, to extend the muscles when there is overload.
Actually, we are taking it from home, sir.
Can somebody please
WhatsApp al kalistira, sir? Okay, sure. Yeah.
Okay, so now the centric relation position is dictated by your proprioceptors and muscles. So because of this deviation, the jaw has moved to maximum intercuspal position. Now, how do we get there? For the condyle, because of the inferior lateral pterygoid pull on the neck of the condyle, the inferior lateral pterygoid places the condyle slightly towards a position where there is maximum intercuspal position. So we need to now ensure, to get the centric relation position, we have to get the condyle in its correct centric relation position in the glenoid fossa. And how do we achieve that? We have to ensure that the muscles are removed from their chronic memory, or muscles lose their engrams, and that is also done by removing the proprioception. So this chronic, or the memory which the muscles have developed in the maximum intercuspal position, is known as engrams. This is a jargon. So this is basically, it refers to the muscle memory. Now, to remove the muscle memory, we have to use a device where the muscles, especially the inferior lateral pterygoid, inferior head of the lateral pterygoid, relaxes, and there is no proprioception from the teeth. So that is where the deprogrammers come into the picture. So this is a description of how the proprioceptors from the teeth send signal to the inferior head of the lateral pterygoid whenever there is a high point, and then the inferior head of the lateral pterygoid tends to move the jaw, and then it establishes the MIP in a slightly protruded or a deviated position, and the condyles do not seat in the correct position in the glenoid fossa. So to record the centric relation record, we need a deprogrammer. Now, there are various, what exactly does a deprogrammer do? So a deprogrammer, it relaxes the inferior head of the lateral pterygoid muscles, it removes the muscle engrams, and a tripodization of the mandible is achieved, and thus it helps in registering the centric relation position. So whenever there is an anterior stop by means of an acrylic or whatever, like Coe's deprogrammer, Lucia Jack, or a stabilization splint, whenever an hard substance is placed in between the central upper and lower central incisors, which causes the posterior teeth to completely disclude. That's the criteria. So when you have something placed in between the anterior teeth, you have to ensure that there is no contact of the posterior teeth right till the last molar. There is absolutely no contact with the posterior teeth, so therefore proprioception is removed. Since there is no proprioception, there is the inferior head of the lateral pterygoid muscle relaxes. As the inferior head of the lateral pterygoid muscle relaxes, the elevator muscles gradually aid in positioning the mandible into the glenoid fossa, or the centric relation position. This is the whole crux of the deprogramming. That is, when the anterior deprogrammer is placed in between the central incisors, there has to be posterior disclusion, and this disclusion causes the proprioception to be removed from the teeth, and the inferior head of the lateral pterygoid relaxes, which aids in the other elevator muscles to position the condyle in the glenoid fossa. There are various types of deprogrammers. There are many classifications as well. There is one classification which is available which says that deprogrammers with anterior stop and without anterior stop. I'm going to focus mainly on the anterior stop. And another classification which says you have short deprogrammer, intermediate deprogrammer, and a long-term deprogrammer. Now, I will not refer to the long-term deprogrammer here simply because a long-term deprogrammer, what they refer to is known as a permissive splint, which is given for temporomandibular joint disorders, where you have clicking noises and you need, it's a chronic TMJ case. So I will not talk about it. Within this purview of this particular webinar, I'm going to talk about short-term and the intermediate or the long-term, what I refer to, and then mainly with anterior stop. Because deprogramming without anterior stop, that's another way of achieving centric relation, that is guiding the mandible into the centric relation position by means of Dawson's bimanual manipulation technique. We will reserve this topic for the next webinar or the next, if Dr. Anand and Dr. Girish decide to do full mouth rehabilitation, we will be talking about Dawson's bimanipulation method at that time. So the short-term deprogrammer is basically, you could do it in your clinic. And this takes approximately 5 to 30 minutes. A simple one is by using cotton roll. You could use a cotton roll between your upper and lower central incisors, but the cotton roll is not a rigid one. And with the help of cotton roll, you cannot register a centric relation record. So next is Lucia jig. It is one of the most popular and one of the original deprogramming method. You can use a clear acrylic in between your upper and lower teeth. And now you have these prefabricated ones which are available online. And you can customize it by relining these prefabricated Lucia jigs. You can use it in your clinic, and you can make the patient sit outside in the reception or the chair side for 10 to 15 minutes, or probably half an hour. And I will talk about how do we know when the deprogramming is being done. So in this, ensure that the last molar is two things very, very important. You have to ensure that the last molar is completely out of contact, and you have to ensure that your interincisal distance between the upper and lower incisors does not cross a limit where the condyles begin to translate. It's very, very important, these two things. So next is Lucia J, leaf gauge. Now, leaf gauge, this particular leaf gauge I've been using in my clinic for the past, I have got a very emotional attachment with this because this was gifted to me by my late professor, Dr. E.G.R. Solomon Sir. And he was the one who has given me the thesis topic during my postgraduate days. My thesis topic was on leaf gauge. So those days I'm referring to way back in 95, 96, we did on leaf gauge. So this has a lot of advantages because this is basically made up of mylar strips. And these mylar strips are of 0.5 millimeter thickness, and you can insert X number of mylar strips, and to ensure that the back teeth or the posterior teeth are completely discluded. As a patient goes on biting on this, the tripodization of the mandible happens. And then another most important thing with leaf gauge, what you could do is you can remove certain number of leaves to check if there is a primary initial contact. If there is only one contact, what you can feel with your articulating paper in the posterior teeth, that means it is definitely an interference. And if you feel that on an incline of the tooth, definitely it's an interference. But if you feel multiple contacts, that means there is not much of MIP happening, not much of a slide from CR to MIP. And the other advantage of using leaf gauge is you can use your bite registration material simultaneously with a leaf gauge. The other commonly used deprogrammers or NTIs, nociceptive trigeminal inhibition tension suppression system, Cranham deprogrammers, Dawson bead splints. Then you have Dana jigs, Dana Lucia jigs. So all of them primarily act on a simple principle, posterior disclusion and anterior stop, so that the lateral head of the inferior head of the lateral pterygoid relaxes and there is posterior disclusion. Next, coming to the long-term deprogrammers. Now, the long-term deprogrammers are used from 2 days to 30 days. So especially when you have a patient who has this particular devices are used in patients with occlusal muscular disorders. When you suspect there is some muscular issue, somewhere there is a problem which is leading to as a clinician, you need to be able to differentiate this. When to give a long term, when to give a short term. And then you have to, this is one of the best deprogrammers which are, you can do this in your chair side itself, or your assistant can fabricate this with a certain class and a clear acrylic resin and with a stop in the anterior teeth. So this is, I have this video where so here we are checking, we are asking the patient to go on biting and closing, biting and closing. Most important is to check if there is only one point of contact. So after a period of deprogrammation, the patient will bite only on a single point of contact. If there is a back and forth contact, or if there is a movement, that means deprogrammation hasn't happened. So dear doctors, you have to ensure the classic way of checking after 20 minutes when the patient comes back to sit in your chair, you have to ensure that there is only single point of contact repeatedly when the patient opens and closes, and the patient should be easily able to do this without any guidance. So here I'm trying to show you the single point of contact. Ideally, Coe's deprogrammer talks about only having a 3 millimeter wide platform. But when you have, I have slightly modified, I've increased the size so that I have, since the lower incisor is slightly treated, I've got it slightly broader, and that is the single point of contact of the lower incisors. Once we get this, again, another advantage of this Coe's deprogrammer is you can simultaneously record your centric relation with this particular appliance. As what we have done earlier, I had mentioned earlier with leaf gates, similarly you can do with a Coe's deprogrammer as well. So this is a single point of contact, and then we go ahead and we use a rigid bite registration material. I think we're having some issues with the relaying platform. I hope all of you are able to see this particular step. So we inject the centric relation the bite registration material, and we ask the patient to close the jaws gently, and the patient automatically, without any effort, goes back into the same position. That is the deprogrammed position. So the next is, these are the centric relation records, what I've obtained. Please remember, your centric relation record cannot be perforated. Most important, the centric relation record, because it is independent of tooth position or tooth contacts, the centric relation record cannot be perforated. The coarse deprogrammer can be made with the help of a traditional PMMA acrylic, or it could be milled or printed. This is something by Occlusal, and this is a method of deprogramming which has been advised by Occlusal. If you'll have gone through your Occlusal textbooks, this is something before we fabricate the stabilization splint, and we can do this deprogramming either in the chair side, or you can give the patient to wear this appliance for 24 to 48 hours. It is made of a heat compressed thermoplastic sheet, and palatally, on the palatal side, we add a little bit acrylic, a flat platform, and the same principles like your coarse deprogrammer. And we ask the patient to close. As the patient repeatedly closes, there is complete posterior disclusion. As the patient contacts only on this point, the mandible gets tripodized. Okay, so the mandible gets tripodized, and that is when the jaw is, if the patient is repeatedly coming into the same point again and again, even after 24 hours or 48 hours, that means the jaw has been, the mandible has been deprogrammed. And then I go ahead, because here I suspected some occlusal muscular disorder, so I thought of giving a stabilization splint. Now, I placed clear acrylic to the posteriors, and I ensured that there were flat contacts on the posterior, and only canine ramp is given. Why a canine ramp? Most of the times, whenever you have patients coming with occlusal muscular disorders, the canine guidance would have been worn out. Literature has shown that whenever you restore such patients in canine-guided occlusion, or you provide a canine ramp in your occlusal appliance, the temporalis muscle and your other elevator muscles, the activity of the muscles drastically reduces compared to a group function occlusion. Therefore, in protrusive and laterotrusive, it's imperative that you give a canine-guided occlusion. Another one, what I would like to talk about is the Lastman technique. This is a technique which has been, it's a modified coarse deprogrammer. So the patient has a coarse deprogrammer. Now, there are two things here. The first one is, suppose you have patients who have malaligned lower anterior teeth, and the lower anterior teeth which are crooked, and you're not able to get a correct stop. So what Dr. Lastman advises is, he advises to make a bite block like this over the lower anterior teeth so that the incisors are aligned and you can get your deprogramming stopped. The other one, what he advises is, after 2 weeks of wearing the coarse deprogrammer, recall the patient back to register your centric relation record. So just before you register your centric relation record, he creates a small acrylic stop in between the two central incisor, which has a small depression into the platform here. So this particular position, since the patient has been deprogrammed after verification, this particular position, this pin goes and locks into the depression in the platform. The reason is, you can use this to record your centric relation at a precise vertical dimension, and the patient does not move while registering the centric relation, the bite registration. So applications of the deprogrammer. So sometimes when you have difficult bite registration patients, you can use a deprogrammer, make them wait in your, in your office for a few minutes or a few hours, half an hour, and then you can register your, you can register your centric relation record. It could also be used as a diagnostic tool. So the benefits are plenty. It has been shown that in patients with a centric prematurity, or the patient has gone into maximum intercuspal position, which has been introduced for a short period of time, a percentage of them may take days or weeks to lose this muscular engrams, and then the prematurity could be removed by means of a deprogrammer appliance, like a leaf gauge. And some patients will not deprogram instantly or in few hours. In such cases, it's better to give them a long-term deprogramming devices. And the other one is, if the patient, as I've mentioned earlier, the patient should be able to close into the same position repeatedly. That is when you know that you have achieved deprogramming. So this is the patient is deprogrammed and she or he reproduces the same single spot on the platform without guidance or support. And the spot needs to be absolutely flat with no slide, and the spot must be repeatable. If the patient is not able to mark on the same spot, and if it is going on to and fro, that means the patient requires some more days of deprogrammation. That is when you decide whether he requires a short term or a long term. When should we avoid deprogramming? Very interesting. So anterior deprogramming should be avoided whenever we suspect intracapsular pathology of the joint, when the patient has pain in the temporomandibular joint, and in cases of parafunction like bruxers. You try giving a bruxer, nocturnal bruxer, you try giving an anterior deprogramming and call them after a couple of days. You don't find much of a difference. Why? Because nocturnal bruxer, no matter you give a deprogrammer, will not stop grinding, will not stop the jaw movements, simply because the sympathetic nervous system gets activated sometimes in the night due to emotional stress, due to airway issues, or plenty of other reasons where his heart rate can shoot up and the muscle can go on rampage, especially inferior lateral head of the pterygoid. In such cases, anterior deprogrammer just doesn't make any sense. So try and avoid giving anterior deprogrammers in bruxers. I hope I have made the stand on deprogramming and centric relation recording and my maximum intercuspal position very clear. Thank you so much, everyone, for watching this webinar. And we look forward to your participation in our upcoming programs and upcoming webinars. Thank you so much.
Thank you, Dr. Shilpa, for that wonderful presentation. If any of the participants have questions, please leave it in the chat box. Now, if I can request Dr. Swaroop or Dr. Gauri to play the video for the COIS deprogrammer, which is digitally made, that will be great. So today, a lot of these workflows are all digital. So if you can see this is the Exocad video where we are designing a COIS deprogrammer. This is done from 3Dent. So you import the maxillary and the mandibular cars. You see how the undercuts are, because the surveying today is totally digital. You don't have to put it on the surveyor. So you decide the path of insertion, and then you draw the margin. Go ahead and create a plate, bring in the lower jaw, see how much of contact you want. You're just giving 2 teeth contact in the anterior, sometimes even lesser than that. And then the posterior disocclusion, as Dr. Shilpa re-emphasized, is most important. Check the thickness. You don't want it to be too thick because you want patient compliance. You want patient to wear it. You cannot give it more than 2 millimeters thick. Anteriorly, the amount of amount of thickness that is desired is again less than 2 millimeters, so that posteriorly you have disocclusion. So you check all these things, and you can print this in a 3D printer and hand it over to the patient. Most often, you would not require to do any clasp work on this because the path of insertion and the amount of undercuts will be adequate to hold on to it. But sometimes you might also have to introduce a clasp, for which you need to go through an analog workflow. So as Dr. Shilpa has very clearly enlisted the indications, the contraindications, the need for deprogramming itself, just to re-emphasize, so if you go back to your basics, like how complete dentures were done, you remember when you are taking centric relation records, so there is two records, right? Centric relation position and centric occlusion position. Centric relation position is, it's a jaw-to-jaw position, which is recorded when there are no teeth in contact. The moment the teeth come in contact, the position of the jaw changes. So if you remember some of your fourth BDS or the internship complete dentures which you have recorded, the patient gives you a perfect class 1 relation, and you're so happy, and you give the denture on the day when your tutor or when your teacher is coming and just pushing the mandible back, he gives a class 2, and you say, oh my God, I fabricated the whole denture in a wrong articulation. So that's the danger of not recognizing where the centric relation position is. And to build any type of occlusion, the only repeatable, reproducible position that is there is the centric relation position. That's the importance of centric relation. So what did you do when you had a wrong relationship in complete dentures? You would go back, trim off the posteriors, right? And then you would take a position before the teeth contacted, which is called as a pre-centric position. What is a pre-centric position? Pre-centric position is a centric relation position recording, which you're doing with the denture for clinical remount, so that you don't have interference. Of course, you know what clinical remount is, right? When you've got the wrong articulation in a complete denture, you have to do a clinical remount procedure to correct it. So you would record a pre-centric record. So once the teeth come in contact, the proprioceptors take up the precedence and they change the position of the jaw, which you do not want at the end of the day. You want to record the pre-centric position and do the articulation and drop the pin a little so that the first contact is seen on the articulator. Then you correct the occlusion or build the occlusion and do it correct. In the same way, when you do a full mouth rehabilitation or some kind of occlusal reorganization, it need not always be occlusal rehabilitation in the form of crowns. It can just be equilibration. So the patient is having a central incisor crown which is just breaking off. That is because of a posterior interference. Patient is touching, gliding, and breaking the incisor there. Okay, it can be as simple as that, where you want to identify where this interference is. So at that time, when you want to do it on an articulator or in the mouth, you just go ahead and probably use a leaf gauge or use a cois deprogrammer, deprogram patient and see where the first contact is and go ahead and correct it. That's the way the thinking process should be when it comes to deprogramming. So it is important to identify the centric relation position and the maximum intercuspation position. And if it is different, there was a point in time in the history of restorative dentistry that they were considering the maximum intercuspation position, which is different from centric relation position. If it is different, if it is not coinciding, which is 90% of cases, as Dr. Shilpa said, only 10% of patients, the MIP coincides with the centric relation position. So they would rehabilitate all these patients so that the maximum intercuspation position is in centric relation position. You know, even asymptomatic patients, patient comes to you just for an examination, they would just do a Dawson's bimanual or a leaf gauge and try to identify, oh, you have a centric relation which is different from maximum intercuspation position. So let's go ahead and give crowns to all of them. That theory is gone out of the window. You know, you do not interfere with occlusion if the patient is not symptomatic. If there are no signs and symptoms, you do not go ahead and do anything. In the sense, if there is no breakage of a respiration, if there is no excessive tooth wear disease which is there, if there is no muscular problems which is there, if there is no joint problems if it is there, you do not rehabilitate. Just because there is no coincidence of centric relation to MIP, you do not rehabilitate. If and when you are rehabilitating, you have identified this patient requires a full mouth rehabilitation for whatever reason. That the only position that you have to build a centric occlusion is in the centric relation position. That is the reason why you have to take out all these engrams and do all this exercise of deprogramming before you record the centric relation record. So you have to do it. If you're doing full mouth crowns, for example, you have to do it twice. First of all, when you are doing diagnostics, you put the COIS deprogrammer about the leaf gauge and make the pre-centric record, as I was telling you, and mount it on the articulator, on the semi-adjustable articulator, which you've done a phase-go transfer and all that, and study the occlusion first. The second time is when you are actually fabricating the crowns. So 2 times you're going to use the deprogrammer to go ahead and do this particular exercise. Okay, so many more steps of full mouth rehabilitation is going to come, and we are going to talk more about it. Of course, I think there are some questions which are popped up there. Oh, that's a very interesting question. How do you deprogram when anterior teeth is missing? That's a fantastic question, Dr. Shilpa.
Yeah. So whenever anterior teeth are missing, and suppose you have only the posteriors present, I would recommend that you do a prosthesis or a removable partial denture you give, and you provide a stop. The primary criteria of your disclusion, posterior disclusion, is maintained. And then your inferior head of the lateral pterygoid relaxes. That is a primary criteria of a deprogrammer, and this is how you could do the deprogramming.
That's wonderful. So if there is a very deep bite and you can't even give a prosthetic plate there, see, best thing is to give a plate, right? To give a plate partial denture, which with a little height, so that itself will act as a deprogrammer. That is one thing. You could also think of deprogramming by disoccluding the posteriors. Why something like an equalizer or something like that. There are devices where you just do only on the posteriors. You put a disocclusion device on the posterior so that it is soft and the teeth do not contact, and you lose that muscle memory of where actually you are contacting. That's another possibility. But the simplest thing is to give a plate partial denture with a little thickness on the palatal side so that the posteriors disocclude. And the next question, which will be there, also if the patient is a bruxer, we don't need to deprogram, then what do we do in this kind of patients in full mouth rehabilitation? So, if a patient is a bruxer.
Okay, the patient is a bruxer and you cannot deprogramming for whatever reason. In such cases, as Dr. Anand just mentioned about equalizer. So this equalizer is a fluid-filled, device. This goes and sits on your posterior teeth. So it goes and sits on the posterior teeth with nothing in the anterior. So the upper and lower teeth are sort of separated. So the muzzle engrams are removed. Now, how do you record centric relation in such patients? With an equalizer in place. So what you have to do is, with equalizer in position, in place, because equalizer contacts only the posterior teeth, not the anterior. So when you have to get your bite registration record and first place it in between the upper and lower anterior teeth, remove the equalizer and then place the bite registration paste to the posteriors. So then you have the bite registration material as one single unit.
So also, if a patient is bruxer, I think overnight deprogramming is something which is not advisable. But if it is a patient who comes to your office, I think chairside deprogramming for a few hours, if you can give a deprogrammer, that should be good enough so that so that you can start recording the centric relation position.
Yes,
But of course,
I could
it's
do
a big
that. Yeah.
challenge. It's a big challenge when it comes to bruxers and when it comes to occlusion. The next question by Akshita is, how do you re-verify the obtained centric relation if the patient is a habitual or case of decreased vertical dimension? I think there's a bit of,
Can you
how do
repeat
you
the question,
re-verify
please?
centric relation?
Sorry?
The first question would be, how would you re-verify centric relation? I think that's the first part of the question.
As I mentioned, when you have a deprogrammer, and especially post deprogrammer, and the patient or a stabilization splint, where, like the initial portion is a deprogramming device. So you can ask a patient to repeatedly close into that particular position. So that is when you know that the jaw has moved into the centric relation position. You use a articulating paper and keep checking for the mark. And if you feel the mark is moving to and fro, back and forth, that means the patient is not being deprogrammed and the jaw is not gone into centric relation position.
So if I may add, I think 2 sets of records also is something that will help, because many times they will be putting the marks in the same position, but when you ask them to bite with the bite registration paste, though it's very soft and all that, sometimes there might be a certain amount of movement that can happen. One is to take 2 sets of records and compare if it is just coinciding. The simpler thing to do today is to kind of use the scanners. That is a very good thing to record just the positions. It's fantastic. So if you run the scanner with the anterior deprogramming device, just the posteriors, if you can record, that is what I do regularly now. So that thing is recorded as kind of a photograph, and that gets fed into the software, and you can get that pretty much accurately. The second question was relation if patient is a habitual or in case of decreased vertical dimension, how do you re-verify centric relation? That is something that I did not understand the question. How to re-verify obtained centric relation if patient is habitual or in case of decreased vertical dimension? Probably that question is not very clear. The next question is, would the fluid field equalizer further enhance the bruxing habit? Does equalizer further enhance the bruxing habit?
Because in equalizers, the posterior teeth are out of contact, but the bruxism it's a central nervous system mediated disorder. So whether you have equalizer or any other, why we are using equalizer is only over a short term, where the upper and lower teeth don't meet. So the proprioception is removed. But when it comes to bruxism, you cannot stop it because it's a central nervous system mediated disorder. And now you have a different branch of sleep medicine, that is dental sleep medicine, which correlates bruxism with a huge other issues, like you have airway issues and, temporomandibular joint disorders. So many other factors come into play, but bruxism cannot be stopped with equalizer.
Yeah, does it enhance bruxing habit? I don't think
it does not enhance. See, it's a muscle-mediated disorder. As I said, it's a CNS-mediated disorder. So the muscular movement still happens, whether you have an equalizer or whether you have an anterior deprogrammer. It still happens.
Yes, it does. Yeah. So the next question is deprogramming necessary in patients with stable occlusal contacts if you want to rehabilitate the patient in a confirmatory approach? I mean, as a rule, you would do it for all patients. You might think that the contacts are stable, but if you're doing a rehabilitation, it is better that you deprogram and you record the correct centric. Because how do you know that the stable occlusal contact. The patient might have fantastic intercuspal position, or he might be in the exact same occlusal contact. But how do you know that it is just not a learned contact, or it's not just a habitual contact? That is something. So as a rule, if you follow it like a protocol, it might be just a centric relation position. The patient is maximum intercuspating, so it doesn't matter. But if you still go through the process of deprogramming, you're at least 100% sure that you have not recorded a habitual centric and gone ahead and done the whole rehabilitation, and then you start seeing interferences and things like that. You know, I hope I'm clear on that.
Excellent. I think we have answered all the questions from our participants. I would like to convey my heartfelt thanks to Dr. Shilpa, our guest speaker for today, for giving us valuable insights on details of biology of muscles, how a deprogramming is done, how different splints are used, and what is the best way out for this. I'm sure all our participants have a lot to learn from you, ma'am, in the further discussions that we have. I also would like to thank Dr. Anand Krishna for putting his valuable insights into this webinar. And with this, I would like to introduce and announce the full mouth rehabilitation course to all of you. A full mouth rehabilitation course, a methodical approach, is a 2-day program that we are launching on the 1st and 2nd of September 2023. I'm sure that all of you who have attended the webinar are very interested to know more about this, and I'm sure that you will encourage and tell your other colleagues also about the course. This course is a very comprehensive course which encompasses all the aspects of full mouth rehabilitation in a methodical way, uh, th- starting from diagnosis to orientation of the jaw relation using face bow, deprogramming, how to understand vertical dimension, how to do the lab processes, tooth preparations, digital impressions, and what are the materials available to restore full mouth rehabilitation cases, and understanding concepts of occlusion and a complete digital workflow from start to finish to do a full mouth rehabilitation case. We are very excited to once again announce the full mouth rehabilitation program, a methodical approach, on the 1st and 2nd September 2023. Looking forward to having all of you join the course and make the best use of our leaders and mentors in prosthodontics to help you understand the process and give value to your patients and help them through their issues. So once again, I would like to thank all of you for being a part of this webinar. I would also like to give a small insight about other programs that we have from the Global Dental Academy. Starting with few of our implant programs, we have the Foundation Implantology, which is a completely online program. We have our signature fellowship in implantology, which is for the beginners. They have the We have a module based system where we teach you both the surgical aspect and the prosthetic aspect of implantology, so that you get a holistic approach to treat your patients. We believe that every dentist should be able to place an implant, so all of you are invited to join that program. We also have advanced prosthetic implantology, where we teach a lot of advanced prosthetic concepts which is involved in implant dentistry. We have advanced surgical implantology, where we teach a lot of bone grafts. We teach a lot of sinus lifts, do it on the animal heads as well as the cadaver. So that's going to be a very interesting module and the course that we have. We also are coming up with a lot of other interesting courses, such as courses in digital dentistry, and the one which is which you're seeing on the screen, which is the full mouth rehabilitation course as well. From the family of Implant Study Group and Global Dental Academy, I invite all of you to keep in touch with us, inform us about your progress, register to our courses so that you will be benefited and your patients will be benefited in turn. So I would like to once again thank Dr. Shilpa Shetty ma'am and Dr. Anand Krishna sir for taking us through this beautiful webinar. And I also thank Dr. Sai Swaroop for moderating with me and Dr. Girish Rao sir for joining us and the entire technical team of Global Dental Academy who have helped us through this webinar today. We are coming up with a lot of other webinar sessions through the following months that we'll keep in touch with you regarding what's going on. Thank you once again, and signing off from today's webinar. Thank you very much, all of you.
Thank you. Thank you.
Thank you.